Hi everybody, Mike Putman from the Medical College of Wisconsin, reporting to you from ACR Convergence 2025. And today I'm here to talk about abstract 0891. This is methotrexate versus tocilizumab for the treatment of giant cell arteritis, also known as the METOGiA trial. Now this is a trial that I've been waiting for some time. Very important clinical question. It is an open-label, randomized controlled trial from the French Vasculitis Study Group that pitted methotrexate against tocilizumab for patients with giant cell arteritis. Now, this is an interesting question because we have established that tocilizumab is a standard of care, had great evidence against placebo, but there's been this lingering question about whether or not methotrexate would be sufficient, and so they designed this trial. Now, the funny thing is that there's a lot of weirdnesses here, and I'm going to try to highlight those as we go along. The first weirdness is that the primary endpoint for this trial was actually assessed at week 78, which is fully half a year after they stopped giving the patients the medications. So I would mostly recommend looking at the week 52 data because I think that's quite a bit more useful. And then the second weirdness here is that this was a non-inferiority study. So they're saying, is methotrexate just about as good as tocilizumab? Usually when we do non-inferiority studies, it's things like a DOAC compared to Coumadin, where Coumadin is objectively horrible, and if a DOAC is just as good, then great, that's a win. In this case, tocilizumab is objectively pretty good, and methotrexate has more side effects, so I was already a little bit skeptical about that. And once you get to the results, you'll see more. So what did they find? They randomized 218 patients to one of these therapies. Very big accomplishment. French Vasculitis Study Group does great work. I think that alone is really impressive. Week 78 didn't meet their non-inferiority endpoint, so the trial was technically a failure for methotrexate. But the data that I'm more interested in is the rate of relapses at week 52. So at week 52, higher rates of relapse-free survival for tocilizumab, 83% versus 67%, and PRED-free remission, 81% versus 60%. So that means if you have a patient with giant cell arteritis and you say, I'm going to give them methotrexate instead of tocilizumab, every fifth time you do that, someone is going to have a flare. That is just not good. So I think those are pretty strong votes for tocilizumab in favor, or as opposed to methotrexate. And then there's weirdness number 3, and this is a very weird thing. So in this study, there are a roughly even rate of adverse events, infectious adverse events, but the patients who got methotrexate, 5 of them developed PJP pneumonia, and 1 of them actually died, which is a really horrible outcome. Methotrexate is not something we think of as causing a lot of PJP, but usually we're giving it to patients who have rheumatoid arthritis and are on maybe no steroids at all. So it seems to me that the combination of high-dose methotrexate in this trial and high-dose steroids is actually a pretty big risk factor for PJP, because we just do not see PJP in GCA outside of this trial. So a very surprising finding, and one that I actually think might generalize. So if you're looking to give someone methotrexate and high-dose steroids in any other case, I would be very, very hesitant about that. So conclusion, don't use methotrexate for GCA. I think tocilizumab remains the standard of care. I would favor upadacitinib, abatacept, maybe even something else like leflunomide before I got to methotrexate. I already had a couple randomized trials that were sort of iffy on it, and I think this is sort of the final nail in the coffin for my prescribing of methotrexate in giant cell arteritis. Thanks so much for tuning in. I hope you all have a great day.